All right, question number 98, acute respiratory distress syndrome. As always, we're going to follow the guidelines and we're going to define what the disease process is. We're going to talk about its etiology, and then we're going to discuss some morphology and complications that can take place with respect to acute respiratory distress syndrome. So, what is acute respiratory distress syndrome? It is basically an inflammatory reaction of the lungs. This is the first thing you need to know. So, inflammatory reaction of the lungs, which is characterized by morphological changes that can cause severe hypoxemia and impaired CO2 excretion. So, characterized by morphological changes that result in basically hypoxemia and an impaired diffusion process. This is a little different to what we call diffuse alveolar damage. They're used interchangeably sometimes, but to be able to differentiate between them, you need to know that diffuse alveolar damage is just a term that is used to describe said morphological changes that we're talking about with respect to ARDS. So it's a term used to define the morphological changes, which we'll talk about, that are seen in acute respiratory distress syndrome. Just to give you a brief overview of what these morphological changes are, it includes pulmonary edema, it includes the formation and the presence of hyaline membranes, and it includes alveolar collapse. Right then, etiology, quite simple actually. The cause of acute respiratory distress syndrome is an inflammatory process that occurs in response to pulmonary injury. And so you'll want to know what are some of the reasons or some of the causes of pulmonary damage. You can have direct injury to the lung, or you can have indirect injury to the lung. Direct injury is seen in cases of pneumonia, for example, by toxic smoke, having a near drowning experience, and this basically works because of the differences in the type of water you're going to be drowning in. It can directly affect the pneumocytes and the surfactant that is present, leading to alveolar collapse. Or you can directly have lung injury through stabs or external injuries, whatever, that lead to lung contusions. Indirect lung injury, the most common cause is sepsis, which, as we know, is a dysregulated host response to an infectious etiology. It can also be caused due to pancreatitis, in which case, when you have the inflammation of the pancreas, you have phospholipases that are released into the bloodstream that can again come and harm surfactant and digest surfactant that is present within the lungs. Indirect lung injury can also be caused by something we call transfusion-related acute lung injury, or TRALIs, and it can be caused by drugs. Then the next thing now we need to talk about is the entire pathophysiology, the mechanism, and the morphological changes that take place. So we're going to divide this into two phases. The first phase is the exudative phase, and the second phase is the proliferative phase. So within the exudative phase, the first thing that happens is that you have your noxious agent. We're going to take pneumonia as an example, and we're going to build on this, but just note that the entire idea is that you have some sort of causative agent that causes damage to the alveoli. Should not be saying causative agent causes, kind of gives it away, but either way, noxious agent that causes damage to the alveoli. And because you have damage to the alveoli, you have a release of what we call damage associated molecular patterns, DAMP for short. So, noxious agent resulting in damage to the alveoli results in the release of DAMP. Second, DAMP, the damage associated molecular patterns, and the noxious agent itself can cause can rather activate alveolar macrophages. So DAMP, damage associated molecular patterns, and the noxious agent itself, in the case if it's a bacteria that's causing pneumonia, for example, can activate alveolar macrophages. Now these macrophages in turn go and release cytokines that result in the recruitment of your acute inflammatory cells, and that means I'm just going to put acute inflammatory cells, AIC, which are basically your neutrophils, and this also ends up increasing the permeability of the alveolar capillaries. And so it's really easy to imagine what's going to be happening next, but we're going to go through it anyway, obviously. Fourth, what's happening next is now that because you have an increased permeability simply means that you have an increased leakage of neutrophils, and these neutrophils are going to release, as I've written down here and drawn out for you to have a look at, are going to release reactive oxygen species, which in turn are going to damage the alveolar membrane. And so if you have damage to the pneumocytes that are present in the alveoli, you are going to have necrotic cells. And so this is for the first morphological manifestation that you need to be aware of in the exudative phase. Necrotic cells. Then the other thing that results with increased permeability is, and this is another morphological change you need to know, is the leakage of fibrin-rich exudate into the alveoli, which in turn, because you have some sort of fluid leaking into the alveoli, you have pulmonary edema. So now what we're going to do is we are going to focus on this bit of the diagram I have circled and drawn here. And what's happening here is that your necrotic cellular debris, which we just discussed, along with white blood cells that are present in the alveoli, and the fibrinous or the protein-rich exudate we have, is going to form a hyaline membrane. Histologically, this is just a highly eosinophilic membrane. So we're just going to show it right here. Eosinophilic, so more pink in color. We have the presence of these hyaline membranes now. Now, what's next is that hyaline membranes, the issue with hyaline membranes as a whole is that they increase the thickness of your diffusion barrier. Which in turn results in decreased effective gas exchange, leading to hypoxemia, which was what we said were one of the complications of acute respiratory distress syndrome. And now, because you have this entire reactive oxygen species, a lot of cell death, one of the cells that are present in the alveoli are type 2 pneumocytes. And these, you will remember, are the ones that are responsible for obviously the reparation process, which we'll talk about in just a bit, but they are also the ones that are responsible for the production of surfactant. So you have an overall decrease in the production of surfactant, and because of this inflammatory process, any surfactant that was already there is also destroyed, and so you have a decrease of existing surfactant. No new surfactant can be produced. Existing surfactant is damaged and destroyed. That basically means you cannot hold the alveoli open anymore, and thus the alveoli collapse. And so this is everything that is taking place at the level of the not at the level, but rather in the exudative phase. So the morphological changes, like I said, I've already written them down in yellow for you. Now what we need to talk about is what happens in the proliferative phase, where the healing process takes place. And so in the proliferative phase, you have the removal of the injurious agents plus the healing process taking place as is. And this is mediated by type 2 pneumocytes. These act as stem cells that are involved in the regeneration of the alveoli. Another cell type that is involved in the healing process anywhere in the body are fibroblasts. And from general pathology, you will remember that these are responsible for laying down granulation tissue. So they lay down granulation tissue in the interstitium. And from here on, you have two possible outcomes with this granulation tissue. One, you can have complete healing where this granulation tissue is removed and 100% efficiency is restored. Or you can have so much granulation tissue deposited into the interstitium, which can end up resulting in pulmonary interstitial fibrosis. In this case, you will see that the alveoli have thickened septa. And so this is obviously a problem, because once again, this means you have a thick barrier to the diffusion process at the level of the alveoli, and so hypoxemia is still quite a problematic issue in this case. And just overall, now we looked at the morphological changes that are taking place at the level of the alveoli, but how do the lungs look in this case? Of course, when you have pulmonary edema, you'd imagine you have heavy wet lungs, and the description that is given to these heavy wet lungs when they are damaged and when there's underlying acute respiratory distress syndrome taking place is shock lungs. And so that should be everything for acute respiratory distress syndrome.